Hello and welcome back to the show. Today we have a special guest, Kathy Balson. She is the wealth of knowledge when it comes to menopause. And today we are talking about this unserved phase of the female life cycle, menopause, how it impacts the body, exercise for all the different aspects of menopause symptoms, and obviously the health concerns around this. So I really hope that you enjoy this show. It is a bit of a long one, but it is fantastic. There is so many great pieces of information that I'm sure you're going to be able to take away from today and use in your clinical practice. So please sit back and enjoy. Hello, Kathy. It is so nice to have you here. How are you going?
Good, Courtney. How are you?
I'm
Good to be
great.
here.
Yeah, it's exciting. I've been looking forward to this conversation because I don't think I've actually talked much about menopause on the show yet, from memory.
I
I'll have to
don't
go
know.
back. I don't think so.
I have listened to a number of your episodes, and I don't think so. But you do mention a little bit about menopause in some of your stuff. So
Yeah, well,
yeah,
this will be the first proper dedicated episode, I'm
first
pretty
proper
sure.
one.
Yeah, which is
Excellent.
exciting, and it's
It's exciting.
all
It
on
is
you.
exciting. I was very exciting. I was like, someone wants to hear about it. This is great.
Someone wants to talk about menopause.
Yeah,
Yeah, that's
yeah.
exactly why I actually thought you on the show and bringing this value would be so helpful, because I really do feel like it's the one thing in women's health that is not really like in the forefront of women's health. Like, you don't go, oh, menopause. When someone says women's health, you're like, oh, pregnancy, pelvic floor. That's all I
And
know.
even when you see like a list of women's health things, menopause is normally at the bottom.
And menopause.
That's okay. Yeah. Well, I
Yeah.
suppose it's the last thing in the life cycle normally, isn't it? It's
Yeah,
near the
true.
end of the life cycle.
Yeah.
So
All the women who
yeah.
are going through menopause, they wish it was at the top. They're like,
Yes.
help
Wish we
us.
could do it in reverse. Yeah, definitely.
Oh, so before we dive into all the nitty-gritty, I'd love for you to just introduce yourself, tell everybody who you are, what you do,
Mhm.
what your work's
Yep.
currently like, and
Yep.
yeah, share it along.
Yeah. So I am Kathy Balson. I've been an EP for approximately 23 years. There's probably not a space I haven't worked in that time. Lots of different career trajectories over that time, which has been really great. I did do some women's health work. Probably when I was having my own children, I worked in the pre and postnatal space, which was really interesting. And currently, I'm working in the disability space full time, but I am doing a small women's health work online as well.
Yeah, very, very cool.
Yeah,
Do you know,
yeah.
actually, it was funny that I just put this two and two together when you said you're in the
Mhm.
disability space. Do you have much like women's health and disability ever paired together?
Well, to be honest, if you're seeing a female between the ages of, I think, probably about 40 to 45 and 55, there is going to be some kind of
Mm,
menopausal influence in there somewhere.
yeah,
So while it's never I mean, obviously in the disability space, we are usually talking about NDIS. So
yep,
while it's not like, I guess, a funded condition that the person you might be treating the person for, it's definitely something that impacts on their disability and impacts on their life. Yeah.
yeah,
So
yeah,
yep,
yeah.
yep,
I was just
definitely
thinking
something to
about,
be mindful of.
yeah, I was just thinking about all the
Yeah.
like disabilities that would impact any form of women's health, like even being like pregnancy or even like pelvic floor, bladder
Yeah,
control, like all that. I was just
definitely.
thinking about all about that too. And then almost obviously hormonal
Mhm.
considerations on top of all of that. I was like, oh,
Yep.
maybe, yeah, that'll be pretty cool. Maybe that can be a jam. Combine it.
Could be. Yeah. Get
So
very complex.
yeah, 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 that would be layers.
Yes,
Um,
definitely lots of layers.
So I know I'd love to talk a little bit about your community, because this is actually how I think we
Mhm.
actually really met, really, was through
Oh,
this.
yeah,
You had
yeah.
posted on the Facebook group for SR that you were looking for women, or anyone, men
Mhm,
included. If any of the men are
mhm.
listening, please reach out.
Yes, blokes, we need some blokes.
We need some blokes to share some insight into some things related to menopause. So tell us a little bit about what you're doing with your community and give us a bit of a rundown on this, and then we can go into that a little bit,
Mhm.
a little bit more.
Okay. Well, probably, I mean, the background is I am of menopausal age, and I am definitely going through menopause myself. And I guess, like most people, females included, the message out there is about menopause is not much, but if you get any message about it, it's usually you'll get a few hot flushes, you might get a little bit cranky, and then eventually you'll stop menstruating, and that's pretty much it. Um, and there are so many more factors involved. So when I started to feel like my body changing, and when I started to kind of think, what's this and what's that, and could that be related to that? And I hope it is, because the alternative is I'm going crazy.
I'm
But I
losing my
wasn't
marbles.
going crazy. Wasn't going crazy. There's so many more like aspects to menopause and going through the menopause transition than what I guess general society would lead you to believe. So having a very curious mind, I started investigating all that stuff myself, and was kind of a lot of aha moments and put the pieces together. And then I was like, okay, so I'm an EP. There's a prescription of exercise to help every other medical condition, so surely there's got to be a prescription of exercise to help menopause as well. And of course there is. So I started investigating that, and then I was like, wow, this is really potent stuff, like exercise prescription for lots of other medical conditions. And there is actually quite a lot of research out there if you start digging. And then I just got all really excited and went, I need to share all this, and everybody needs to know about this. So yeah, just had a little bit of a I don't know, epiphany, I suppose, and decided I'd just kind of start up my own little Facebook page, which progressed to Instagram, and now I've set up a website as well. So pretty much it's 80 to 90% exercise-based interventions for menopause in general and all the associated things that come along with menopause, but also there's some other just more general menopause stuff on there as well. So yeah, and my idea was to make it a bit like of a one-stop shop for anything to do with exercise. So yeah, so far I've been able to get quite a few EPs mainly involved in doing some blogs and providing me with their generous time to get some blogs happening and other bits and pieces of information. So it's building, and I'm really excited about it. And yeah, that's where we're at the moment.
Yeah, because this is just a free community for women wanting to learn more about menopause to be a part of.
It is,
That's right,
yeah,
isn't it?
yeah. So my vision for it was that it wasn't going to cost any money, because I can appreciate, there's women out there that, can't afford treatment for lots of things, let alone extras to find out about exercise. And I figure if you're going to really be able to get your message across, you want to make it as easily accessible as possible. And so yeah, it's free. So everything on the website, everything on the Instagram page, everything that I put on Facebook is all free. It's all free access.
I actually
Yeah.
forgot to tell you that I sent a couple of people to your community group because I was like,
Oh,
you need help with
thank you.
your menopause? Like, go here, because they were
Go
asking me. And I was
here.
like,
Yeah.
I'm not really the guru of menopause. I know, your EP stuff, but I feel like you could
Yeah.
just read this. And it was also like, I don't want to teach you everything. Like, just go read what's
Yeah.
interesting to you.
Yeah.
So
Yeah.
I did actually send some people. So
Oh, thank
I hope that's
you.
okay.
That's great. Yeah, for sure.
Yeah.
No, don't send anybody.
So if you're
Send
listening
them
and
all.
you
Send
have
them all.
clients that want to learn more about
Yeah.
menopause,
Yeah.
send them over.
And
What's it called?
it is an inclusive community as well. So it's she community. I try to talk in language that promotes inclusivity. So we talk about female rather than women.
Yep.
Because obviously anybody that has a functioning uterus and ovaries is going to go through menopause, whether that, however they identify gender-wise. And I'd love for the blokes to get on there because they can find out how to support their partner if their partner's going through menopause, and teenagers, kids, whoever, because, I have teenagers and they certainly don't learn about menopause in PDHP at school. Definitely
No.
not.
I always
So
think that like getting your period is this time where your body changes and you're almost a little bit like less like you're not really used to all things in life. So you're kind of like, oh yeah, this
yeah,
happens and like you go through it and that's fine. And then you get all your life
yeah.
and you're like stable and like you know what you like and this is what you do. And then
Mm.
it's like reverse periods and you're like all this change is happening, but you're not as good at dealing with the changing because you're like, I just want to be like this that I used to be. Um
And I feel like what makes you not necessarily as good, and I feel like in a way sometimes women can be a bit gaslighted in that
mm,
they feel like they should be coping with it better because no one's ever said this is a big change. You
mm,
know, it really is, and you hit the nail on the head. It's reverse puberty. That's what it is.
yeah.
Yeah.
So I see
So
it anyway.
yeah, it is.
And
Like
like,
8 to 10 years of perimenopause, which leads up to the final day of your final period. And that's when you're classed as menopausal. And then anything after that is postmenopausal. And even 2 years, up to 2 to 3 years after your final menstrual period, you can still have symptoms. So it could be like 10, 12 years even. So it's even
can it
longer
actually?
than
Yeah.
puberty. Yeah. Yeah.
I was gonna
Yeah.
say sometimes my mum is like, "Oh, it must have been the menopause." I'm like, "Mum, you went through menopause like 15 years ago. Your symptoms aren't there anymore." But I'm like, "Oh, maybe they are."
Well, the general age, I think the average age in Australia at the moment is 51.
Mm,
But given that you can have symptoms up to 10 years prior, so women, if they are going to go through like a normal menopause, they may start to have symptoms at 40.
yeah.
Um, if you go through early menopause, but normal menopause is classed anywhere from 45 to about 55. So if you're earlier in that kind of that spectrum, you might start to get symptoms at 35.
Yep.
And then if you have an early menopause, which can be anywhere between 40 and 50, 40 and 45, you might get symptoms at 30. So we're talking like a big
Right.
span.
Yeah, that's
Yeah.
huge. That is huge.
Mm,
I
yeah.
actually had recently, this is I don't know, maybe it is. I kept waking up in the middle of the night with really hot legs. And I'm pretty sure it was because I was dehydrated. And once I started drinking water, I was okay. But I was like in this zone of like, oh my God, I'm going through menopause. I'm getting hot flashes. Like, I'm only 34 and I'm like, I haven't even had kids yet. I'm like, oh, freaking out. But
Look,
I could.
the outliers are definitely not the majority. So your
Yeah.
outliers would be
Yeah.
a very small percentage. Most women will go through menopause anywhere between 45 and 55. High percentage will be around that, 48, 49, 50, 51,
Yeah.
52.
Yeah.
So
I have a
yeah,
client who
don't
is
start
in,
panicking.
I'm like, it's menopause for sure. I'm forgetting things.
Well,
Um,
it is an excuse to be a little cranky. So if you're having a cranky day,
I'm just going to say that
yeah.
I'm,
You
might as
can
well use it.
definitely say that.
I
You
actually
might
have
be able to
a,
swing it that way.
yeah, 100%. I have a client actually who is really early onset menopause. She'd be 34 and she's like
Oh,
got months without periods and it's like she's had all the tests
yeah,
done. Like you're actually
yeah,
really early onset.
yeah.
Which she was just like, oh, this I'm not going to go through menopause. Like her symptoms were just she
Mm,
just dismissed them because of that.
mhm,
And I
yep,
think she was looking at having children, and then that's when she was getting all these tests done, and they're like,
mm,
oh, actually, you're actually going through
yeah,
menopause, or
yeah, yeah,
perimenopausal. So a little bit
yeah,
sad, but that's super early.
yeah. It is. Yeah, it is. But it can happen. Yeah,
Mm,
and they'll usually test at that age because obviously it's very abnormal. It's not like,
mm,
as I said, it's a very small percentage that would happen.
yeah.
Um, yeah, so that's definitely unfortunate for her.
What tests do they
Mm.
actually run for it? Is it just
So
hormonal testing?
usually they'll just run the gamut of hormone tests. So they
Yeah.
all your reproductive hormones, they'll just test them and see where they're at.
Yeah. Okay.
Um, they don't like they literally sort of will only do it in certain age brackets because it's not indicated in the normal age bracket. So between 45 and 55, it's not indicated because if you are actually going through perimenopause, it's hard to, they don't diagnose it from hormone tests because your hormones are all over the place.
Yeah. Yeah.
But if they did some hormone testing earlier on when your hormones are really stable, then they
Yeah.
can kind of, yeah, then it's more indicative at that point.
Yeah, because you'd have the baseline to compare it to.
Yeah, exactly.
Yes. Yeah, right.
Yeah,
Um, yeah, okay. Well, that's crazy. So
it
I'm
is.
excited
It's
to
crazy.
share a lot more about the research and exercise-based stuff because I think when
Definitely.
so how many topics did you end up getting posted in the community? Was it about 14, wasn't it?
I feel like blog wise, there
Mm.
may have been maybe 8. There's still a couple of
Oh,
EPs
that's right.
to contribute their blogs, which I'm really appreciative of and looking forward to. We have a New South Wales EP actually coming up in October, who is very big in the women's oncology space. So she's kind of one of my little. I'm a bit of a fangirl of her. So I
Fangirl.
can't wait. Yeah, I can't wait to read that one. Yeah, so that'll be good.
Yeah. I love
Yeah,
how you're
and then
talking
I've got
about
it.
blogs. And I was like,
Yeah,
sorry, but can we do videos? Because I'm really good on video.
well, I would love that. I really would. And part of like where I want to take this community is involves me. I would definitely like to get more confident with being on video because I'm
Yeah.
old school. I mean, we talked about before when you weren't actually filming. We talked about the fact that most of what I do is on Facebook because that's the generation. And
Yeah.
yeah, I guess if I was a bit younger, I'd be all over TikTok, but I'm not all over TikTok. So yeah, I would
I'm
like
not
to
on
get
TikTok
more
either,
into,
really.
yeah. Oh, you should be.
I have an
That's
account for it and I just couldn't keep up with all
yeah,
of it. I was like, this is too many.
yeah, yeah.
But
It is a bit crazy. My daughter sometimes shows me some TikTok videos, and I'm like, how do you even watch that? There's way too much happening on that screen. Um,
for 10 seconds.
yeah, yeah. So I would love to do some more video stuff and webinars
Yeah.
and stuff that's a bit more interactive.
Yeah. So that's like the
But I've
long-term
just got to
goal.
push myself to do it. Yeah,
Yeah. Well, I'll
definitely.
motivate you for the videos.
Yeah, yeah, just keep harassing me. Keep
Yeah.
put on
I'm like, I'm
page.
waiting for your
Where's
video.
the video? Yeah, stop with
Yeah.
vlogs. Give
I
me a
just
video.
find I just find the video content so much more like conversational and
Yeah.
talking. And I find it much easier. Like if I had to write like a proper blog, it would just sound like
Mm.
I'm having a conversation with you because I just
Yeah.
don't write that well.
Well, that's fine. That's what they need to be anyway, because we're not. That was something I was really mindful of. Is I want it to be not only accessible in terms of people being able to access the platform, but be able to understand the information. You
yeah.
know, I mean, I'm a believer for putting your references and that at the bottom, because I obviously also want people to know we're not just talking garbage. But yeah, the content, I really want it to be very layman's terms. And I think you've talked about this in your another podcast,
Mm.
especially with your monthly research reviews that you put out. You
Oh
want
yeah.
them to be understandable.
Yeah, because
And if
I
we
read
talk
them
in
and
too
feel
much
dumb.
lingo, then people just don't understand them.
Yeah, 100%. That
Yeah.
the research spotlight emails are the only things that I really write. And every time I'm writing,
Mm.
I'm like, someone is reading this going, this chick does not know how to write stuff.
I feel like you're have the same approach to research as me, and I really don't know how I got through uni with this approach, but I literally am a abstract introduction,
Yeah.
may read some of the results, discussion, and really just skim the conclusion.
Yeah. Yeah.
That's
Yeah,
it.
I must say I've gotten a lot better at reading research for the reason like I probably should read this. Um but I find if I'll start reading and I'll get like I don't know, maybe through the first page and I'm like I don't even know what this is talking about. Like I can't even
Yeah.
understand this text. There's too many words in it. You're using too much jargon.
Mm.
I'm just like, whatever, not good enough. And I just don't even read the rest of it. It's just too hard.
And I always make sure that they're either, a systematic review or a
Hmm.
meta-analysis or both, or a
Something reliable.
randomized control trial. Because then if someone asks you any questions, you're like, oh, it's a great study. It's perfect.
Yeah,
It's
it was a
great.
review.
Yeah, you don't even need to so
Yeah.
if it's a randomized control trial, it's a great study, but then with the reviews, you can go, oh, yeah, they put in all the best studies, and
Yeah, like
it's
they've
a
got to be good.
meta-analysis, so it's yeah. So
Yeah,
then you
someone else
don't
is
have to
culling
read,
the
then you
crap
don't
ones
have to
out
read the
for you.
middle bit. Yeah, exactly. Someone else is doing the hard
True.
work.
True. I feel like I'm a bit now nervous that that vibe is coming across in my emails. You're like,
Are
yeah,
we
it is.
giving ourselves away? Maybe we should start the
No,
podcast
because I
recording
feel
again.
like that's
No.
the point, right? Like so many people talk about it like in
Mm,
really advanced ways. And I'm like, oh my God,
mm.
why should I even be an EP?
And there's so much anecdotal stuff too that you're like, that's what the research said should happen, but that's not what this person's doing. So I don't
Yeah.
really understand what's
Yes.
going on. But you know what? They're a human being and you just go with what
Yeah.
is happening for them. You know,
Yep.
research is not going to capture everything that you ever see as an allied health professional.
Yes. I
Yeah.
do actually remember having an argument with a lecturer at uni about this once. And because I failed the assessment on, I think I had to present a evidence-based exercise prescription for someone who was obese for type 2 diabetes or something. And I started them off with like 20 minutes of walking. And he's like, no, you need 300 minutes. I'm like, mate, this guy has not got off the couch for like 10 years. There's no way he's doing 300 minutes.
He
And it
will
was,
die if he does 300
yeah,
minutes a week.
I had to redo the
Mm.
assessment.
Oh, gosh.
Anyway, moving on. Let's talk about the research really with menopause.
Mm.
I would love to touch on this because when I was looking through the topics that I just told you earlier on
Mm.
who was going to talk about what in your menopause community or she community, I was really
Mm.
surprised at like all the different stuff that was not just like
Not
osteoporosis
just bone. Yeah.
and bone health because I'm like, I feel
Yeah,
like that's
exactly.
it. And maybe
Oh, there is
cardiovascular disease, but
plenty.
there's
There
so
is
much. So can we
plenty.
talk about them? Like, are you happy to dive
Yeah, yeah,
into
for sure. Yeah.
all of them?
And just a disclaimer, this research is good research. It's not just research that I went, read the top, read the bottom. Yeah, that'll do.
The systematic
Just,
reviews.
yeah. Just a disclaimer. Just a disclaimer.
I'll have to
Based on
share
our
them.
previous conversation. Yeah.
Yeah, I'd love to know.
Yeah. Yeah. Well, I guess when you're talking about like menopause, we have to think of it more as a systemic thing. So there are estrogen receptors in literally every part of your body. So um, when you think of it that way, it's just common sense that you're going to have multi-systemic uh, symptoms when you're going through menopause. So a lot more than just you'll get a few hot flushes, you might be a bit cranky, and then your periods will stop. So yeah, you mentioned bone. So that's obviously one of the big factors that we think about when we're talking about women going through menopause, because estrogen is kind of that boosting hormone. And in general, it's responsible for kind of all that, you know, stuff that is growing in our body. Like it's a growth hormone, it's anabolic hormone, it's a regulator, it's a modulator, it's a, you know, it keeps everything else in check. Plus, it's also responsible for most growing type functions in the body. So as that's going haywire, which is what it does first of all, and then gradually on a downward trajectory, and also your receptors become less sensitive as well. So not only do you have erratic estrogen and erratic progesterone as well, let's not forget about progesterone, your receptors are becoming less and less sensitive because estrogen's not acting on them as it should. So over time, they are then like, what the hell's going on? I don't quite know what to do with this hormone. So they're becoming less and less sensitive. And that's happening throughout most of your body. So there's lots of different factors to consider. So probably from my experience, yeah, bone is definitely one of the main ones. That's actually one of the most important ones too, because that actually has the potential to affect someone's mortality. So people can die from hip fractures.
Yeah, wow.
Yeah. So the current research is, I think the age is 50. I should have written this down. 1 in maybe 5 women over the age of 50 will have, it's in one of my blogs, will have at least one osteoporotic fracture. Half of them will have a second, and I think it's something like 30% of women over the age of 50 that have an osteoporotic fracture of the hip, 30% of them will pass away within 12 months of having it.
Really? Why is
So
that? Like, what is it related to?
when you look at the data, it is more of the older women, but obviously because they've kind of said that age of 50, there are some younger women that fit into that group. And it's got to do with just their ability to function. Like once you have a hip fracture, your ability to function just declines dramatically because there's just so many things that you can't do, you know, and there's also risk of infection, and there's risk of all complications. And they may not necessarily die directly from that primary hip fracture, but they can die from complications around the hip fracture and other things that happen because of just, you know, massively declining function. So although that's probably one of the main things that, you know, we think about when we think about menopause, it is really important. It's probably one of the main factors that can affect a female's mortality or anyone's mortality anyway. Yeah, male as well. So I don't think the statistics are as high for males, but yeah, definitely it's still a factor for males as well, osteoporosis as we get older.
Yeah, I just feel like you see the falls of like your older grandparents or, you know, people that you know that are in that category, and then all of a sudden just aged so much because they've like been so dependent on everyone else, and they're losing like memory and like everything's just. And I can see exactly what you meant. I thought that might have been the case, but I wasn't sure if there was something else I was like just did not know about.
Well, there's a proportion that like post-op complications. That's a proportion. And then just other kind of like things that decline, functional decline in that 12 months afterwards. So bone, and then you've also got balance. So balance is a big thing. Estrogen affects your balance. It affects your you know, vestibular system, your peripheral system, so nerves. It also affects parts of your inner ear. Like a lot of women going through menopause will get vertigo. That's actually a symptom of menopause.
Is it?
So idiopathic vertigo that they've never actually ever had before, and there's no like identifiable cause. Balance can be affected, and when you're combining balance with osteoporosis, you've got much higher falls risk. So balance exercise is a big thing. And I know, I can tell you now, like I feel like my balance and coordination has declined in the last probably like maybe 3 years. Like I just don't feel as together with my movements, and I feel like sometimes, you know, like I'm like, where's my handbag and what have I done with my keys and where am I going to put my phone? And it just that even just coordination and things flowing well when you're moving, I've noticed that. And it's definitely a thing. You feel a lunko.
That's
definitely
so
feel a lunko.
Say that, because I did a bit of reading on that with just with the menstrual cycle, like the changes in estrogen. Does it actually affect that? Because I mean, I don't really talk about this. Well, I talk about it a little bit, but I do a lot of motorbike riding, which is a lot of balance. And at certain times in my cycle, I cannot balance on the bike at all. And I'm just like, why am I even doing this? This is ridiculous. And I would say like, oh, it just gets worse like that. And it would just go down. Maybe I am going through menopause.
No.
But yeah, I wouldn't have even thought about like I would just thought that was aging for most of the clients that I've seen who are menopause. But
there's a lot of sometimes with the research, it's like hard to tease out, is it menopause, is it like aging? But there definitely is like, you know, menopause is like an independent risk factor for balance issues. I'm sure, like you said with the motorbike, it's a thing, because I remember when I was younger, like I've always I don't do so much now, but I used to run, and in the winter if it was raining I'd run on the treadmill, and I don't know, I never really pieced it all together, but now I look back and I think, I wonder if it was a certain part of my cycle. Sometimes I'd be running on the treadmill and I'd be like, why do I have to keep touching the sidearm?
You're moving over.
Like what am I doing? Why am I moving? And I'd have to, I remember just having to kind of just, not all the time, not through the whole run, but just occasionally having to touch the sidearm and like, you know, straight stuff. but not having to do it all the time, and just once in a while thinking, why am I just touching the sidearm to stabilize myself? And now looking back, I think, oh, was that like a cyclical thing?
Are you running on the treadmill now?
No, I'm not running on the treadmill.
Are you doing that? Like,
I do a lot of high intensity training on the bike. The bike's my thing these days.
Much more stable.
Yeah, I walk on the treadmill with my daughter.
Yep.
Definitely still do a lot of like low to moderate intensity stuff on the treadmill, which is great for like walking and listening to podcasts. And
you should test the running out and see if you like bang it into the side.
Oh God.
And then you can video it, put it in your menopause group and be like, I get ya.
Like, don't do this, ladies. Don't do this
at home.
Don't do this. Don't try this at home.
Worked on your balance. Yeah. So when you're doing like exercise prescription for it, like, I think we talked about this earlier, like the prescription for balance is the thing, right? Rather than menopause balance. It's not like
exactly. So it's balance. Yeah. And a lot of stuff that kind of gets you a bit off center. So cables are really good for this. So training with cables is a really good way to, get some strength happening and some good movement patterns, but also getting you a little bit off center. So you have to recruit those muscles that are going to stabilize when you're pulled this way or pulled that way, or, so it gets those stabilizing muscles working well. Yeah. I've got a lady that I'm doing a lot of that with at the moment. Yeah, doing some cable work with some lunges and some pulls, as she comes up. So she's, her kind of opposite side of the body's, stabilizing as she's coming out of the lunge, and then pulling,
like side
so you've got those two opposing forces as she's rising and then pulling back. Half presses are great, like to get that,
half press.
Yeah, you can really, I do them myself, and you can really feel that one side having to really work to hold you up. Yeah, and then the further out you go, the further that side, the more that side feels like it's working. Yeah, so cable stuff's really good. Even your traditional balance stuff like tandem walking and standing on one leg, and and I guess it depends on the client too, what their daily life entails, what functional things they feel like they're struggling with. Yeah, right. So balance is definitely a thing. What else? So cardiovascular, that's a big thing. And cardiovascular and vasomotor symptoms kind of go hand in hand. So that's all, and your thermoregulation. So that's all kind of tied in together to do with systemic inflammation. So your estrogen has a role in helping with the anti-inflammatory processes of your body. So when that starts to go a little bit haywire, you get a little lift in systemic inflammation. Your cortisol also is generally higher at baseline going through menopause, which also creates a higher sympathetic drive at baseline. Yep. So women often will have new onset anxiety, panic attacks.
From that, yeah.
From that higher sympathetic drive. And this is, I think I said this to you off recording, but I said it to you at the beginning. When fuming started to happen, I was like, this has got to do with perimenopause or I'm going insane. And this was one of the things I struggled with. Just all of a sudden, claustrophobia. Never had claustrophobia before.
Oh, really?
Started to struggle with lifts. Started to struggle in situations where there were too many tall people around me. Once I went through the M5 tunnel in Sydney, and I was driving along in the car, singing along to the music, went into the tunnel, the traffic started to slow, I had to stop, car stopped inside the tunnel. Instantly, I felt the blood drain out of my face, my heart rate started to rise. I was like, what the hell is happening here?
Wow.
Yeah, just never had claustrophobia before in my life.
Like, what is this?
Out at Jenolan Caves, which is, do you know of Jenolan Caves in New South Wales?
I do know Jenolan Caves.
I was out there with my family, went into the caves in there. I think I was in there for about 5 minutes, and I looked at my husband and I said, I'm going to faint. I need to get out of here. And just like literally grabbed one of the guides and just said, you must get me out of here. I was like, what the hell is happening to me? Yeah, so Yeah, that's very new. Never had it before in my life. Yeah, and just
So
just a heightened level of daily kind of being a little bit more like,
like
irritable,
on edge.
bit more kind of on edge, a
Yeah.
bit more like, why is that person standing there? Why are they looking at me? Like, what's going on? And a
Yeah.
bit more vigilant about things.
Yep.
And yeah, that definitely came with, you know, coming into kind of 46, 47. Yeah,
Wow.
so there's that high synthetic drive.
So like if you like from a prescription or a treatment point of view there, like I
Mm.
feel like that's a red flag for me for clients telling me all this stuff about like pelvic floor tension based issues and pelvic
Mm,
pain and things like
for
that. And
sure.
I'm like,
Yep.
oh, we
Yep.
need to like work on
Hmm.
you being a little bit more like, get this sympathetic drive a little bit more under
Yeah.
control. Is that
Yeah.
something that like have you had to do some of that stuff personally? Like does that actually help when we're looking at it from like this hormonal side or
Well, me myself, I've actually started to do a lot of breath work,
hmm,
um, because I found that in the moment, that's what kind of helps,
like
like
real
me
time use?
calm. Yeah, 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 real time use. Um, and because it's not been a thing that I've struggled with my whole life, um, yeah, I went to my doctor, went to a psychologist. The psychologist's like, yeah, let's just start with some really in the moment stuff that you can do. Like,
Hmm.
let's agree that it's hormonal. Let's agree that it's just that physical, like, you know, um, that physical kind of increase in your sympathetic drive. Let's give you some things in the moment that you can do. I don't think there's any, we don't really need to kind of do any in-depth counseling or anything like that, because I
Yeah,
can't identify that it's,
from like a
a,
previous
a
trauma or
traumatic
something.
cause or
Yeah.
anything like that. And yeah, so that works. And just a bit of planning, like, if I need to go somewhere where I know there's a really small lift, I will take the stairs, which of course is better for you anyway. Um, yeah, and I've gotten myself and it was really funny because I drove through a tunnel once and I was like, there's actually exit doors. And I said to my husband, are they exit doors? He's like, yeah, they're exit doors. And I'm like, so now my brain knows that if I actually get stuck in here, I can get out.
There's an
So
exit
that
door.
solved the
Yeah.
tunnel problem.
Yeah, right. I would imagine they're like opening the doors like, water.
Yeah, I know. That solved like the tunnel problem. I can get out, so that's
Yeah.
fine. But the lifts are still a bit funny. Like, I'm still a bit funny with lifts. I've just got to prepare myself and just, tell myself that no one's ever died. Well, I don't know, someone probably has died in a lift, but I certainly haven't ever had my life threatened in a
Yeah.
lift, so I'll be fine. Yeah.
So if
So
you have
that's
pre-existing
weird.
anxiety or
Mm.
these things, like is it going to just be like next level for people?
It can elevate. Yeah, it
Mm.
can definitely exacerbate it. But there's also, as I said, like, women that have never had anxiety or depression before in their life have anxiety
Yeah.
and depression through menopause. And it is an evidence-based thing that it
Yeah.
it is caused from hormones. Like, there's a really good Australian psychiatrist. She is at the Her Centre in Canberra, ACT?
Mhm.
I think that's where they are. I cannot remember her name, but she's doing a lot of really great research into um, mental health in menopause.
Yeah.
Yeah,
Okay.
yeah, and identifying that it's hormonally driven. Yeah, because if when they look at women, especially with depression, when they look at women in menopause that have depressive symptoms as opposed to women that are, you know, that have been diagnosed with clinical depression,
Mhm.
the symptoms are different. Like,
Ah,
women can fluctuate from day to day. So women with depression that's been identified in menopause, one day they can have it, and the next day they might not.
yeah,
You
because the
know,
hormones are just all out of
yeah,
control.
yeah.
Yeah. Okay.
So and when you look at, like, I guess, and I suppose this is part of the research that they do, trying to match up where the hormones are at that time when women are reporting depressive symptoms. And it's usually a certain combination of progesterone and estrogen on that particular day,
Mm.
that's kind of causing those swings in mood. Yeah.
Yeah. Wow.
Um,
That's really
yeah.
interesting
So,
that the depressive
yeah. So
symptoms are
that
different.
heightened, heightened sympathetic drive, and that also affects your that inflammatory response, and then you've got inflammatory response that starts to affect your cardiac system, so your vascular system. It leaves you open to more like atherosclerosis and hardening of kind of arteries and increased blood pressure and all those sorts of things. So you've got that, your cardiac risk factors do go up quite a lot in menopause because of all those reasons. And that ties into your hot flushes, because your hot flushes are actually your thermoregulatory system having absolutely no clue what's going on, because at the periphery, estrogen's not quite doing its job with allowing your peripheral vascular system to adjust according to whether you're hot or cold, and it's not sending the signals properly back up to your hypothalamus, and then the receptors in your hypothalamus are not sensitive to the estrogen, and so you've got this kind of central issue, peripheral issue, and then your hypothalamus kind of just goes, I don't know what the hell's going on, so I'm going to make you sweat, and then I'm going to make you shiver, and then I'm going to make you sweat because I'm not sure what's going on, so I've got to try and cover all bases.
Okay.
And everything's just in disarray. So there is actually, so it all kind of ties in with that cardiovascular system. And women that have poorer cardiovascular health, have increased body weight, usually will have more severe vasomotor symptoms. Yeah, so with exercise targeting, definitely cardiovascular health can help to reduce inflammation, and can also help to manage that more central visceral fat that kind of builds.
Yep.
And that's also related to increased cortisol, so it all ties in. And then you've got sleep. You've also got sleep that's also tied into all that. Increased inflammation, increased cortisol all affects your sleep as well. And then when you're not sleeping well, your cortisol is then higher, and then that kind of a bit of a cycle of how it all affects that visceral fat deposition as well. So yeah, lots going on metabolically, and then we've got blood glucose that ties into all that as well. So how long have we got?
I'm just like, I remember feeling scared to get my period. Now I'm scared to not have it. Like,
you know what?
I don't want to go through that.
There's two things, right? Education. If you know what to expect and you know how to manage it, so much easier. And the other thing is not all women get all symptoms, and not all women get all symptoms badly either.
Yeah.
So for instance, there's symptoms that I just do not get. And one of my really good friends, we often joke that we're kind of a person split in half, because the symptoms that I get, she doesn't get. And the symptoms that she gets, I don't get. So like,
yeah, so if you put it together, it'd be a disaster.
Yeah, I know. And so for me, like, I'm not going to give you too much information, but the whole pelvic floor, the I can never pronounce the word, genitourinary.
Yeah, genitourinary. Yeah.
I know exactly what it is, but that word just stumps me all the time. Pelvic floor, genitourinary stuff, I don't get any of that. I'm totally good with all that.
I could help you.
Oh, I know. I'm waiting.
You're like, I've just got you on speed dial ready to go.
The bottom totally hasn't dropped out of the hormone bucket yet. So
I think it's crazy that the symptoms aren't the same in people. Like, it's estrogen and all of them are bad. Like, why do some people get the most insane, like, night sweats and hot flushes, and then other people don't even have one of those, but have like all the other stuff that might be, just other stuff. So like, why? Like, why does that, like, they don't even know, do they?
Well, a lot of it is lifestyle, to be honest. So if we think about exercise, diet, alcohol, weight, so those factors are very big. So women that eat really well, I think and I'm not a dietitian, obviously, so I'm not going to go out of my scope of practice, but generally Mediterranean style anti-inflammatory diet
Yeah.
is
Okay.
best for menopause. Exercise, 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 exercise. Reducing alcohol, because alcohol increases inflammation, messes around with your mood, stops you from sleeping
Oh,
because it
yes.
messes around with your sleep patterns. And God, what was the other thing I said? And women that are heavier, more overweight, will generally have more severe symptoms. Yeah.
Yeah, right.
And that's why sometimes women that are, when you're talking about more obese females, unfortunately, it's very hard to diagnose menopause because a lot of those symptoms they might have already been getting because of,
Health.
metabolic syndrome and thyroid
Yeah.
disorders and all that other stuff that comes along with being morbidly obese. Yeah. So
Yeah, okay.
that's a tricky one. Yeah.
And
So
so,
lifestyle is a big factor. You can do lots with lifestyle. And you can also have hormone replacement if you so choose.
I think the
And
hormone
if it's
replacement
indicated.
stuff has just been a
Yeah.
bit like shadowed and like, oh,
Yeah.
HRT. And I'm like, mate, it's like I'm pretty sure it's pretty minimal even compared to the pill in terms of
Well, there
dosing.
was a big study done on, don't quote me on the years, but the Women's Health Initiative study. I
Yeah,
think it was
the
about
study.
20 odd years ago. Some of it was great, some of it was not. The way some of it was reported in the media was very bad. And so it freaked everybody out, women, doctors included, the whole lot. And I think we're only just recovering from that. We're
Yeah.
only just starting to go, hang on a sec, what aspects of hormone replacement did increase someone's cardiovascular risk? And what was the age of those women? And hang on, those women were already postmenopausal and probably had increased cardiovascular risk anyway.
Yeah.
What type of issues, what type of hormone replacement were we looking at that caused the increase in breast cancer? Number one, that's not used anymore. And number two, it was generally, when you look at most studies around it, it was a synthetic type of progesterone included in the mix that kind of had the higher risk for, increased breast cancer. But even when you looked at that over the whole, risk, it was a minimal increase in risk anyway. And when you're thinking about women in Australia on hormone replacement or not at the moment, I think it's 1 in 9 or 1 in 8 women will get breast cancer anyway, whether you're on hormone replacement or not. And the risk factors that are coming up out of women being on hormone replacement are actually less than the general population. So it's kind of like, yeah, anyway. But when it comes to that, it obviously needs to be indicated. It's, a branch of medicine that, you need, obviously women need to go and consult with their doctor.
Yeah.
But yeah, definitely it's starting to there's more and more research coming out to show that it actually helps with a lot more than just the vasomotor symptoms, which is generally what it's prescribed for.
Yeah.
They're doing a lot of research into cardiac risk, dementia risk, brain health, mood, all those sorts of things. And there's lots of research coming out to suggest that it's beneficial in those areas as well. But yet, doctors aren't prescribing it for that yet, because obviously they have their medical guidelines, and we all know that medical guidelines take a long time to change after research.
Oh, don't we?
So that's a whole nother topic.
That's a episode number 2.
It is. Yeah.
Yeah.
And I try not to get too into it because it's not my scope of practice. It's not related to exercise. So yeah. But anyway,
but it is like, it's still
it's going to come
interesting
up. It's always going to come up when you are talking about
and like,
menopause.
I also look at it like quality of life for people. Like if someone's really struggling with like, your depression symptoms,
Yeah.
you're like, and they're stopping doing activities and being social, like there's a point in time where you're like, like,
Yeah. And it's
might
always
be a
down
good
to
way to
quality of life.
consider. Yeah, like, and
Yeah.
it's 10
Quality of
years. It could be
life.
10 years. Like,
Yeah. Yeah.
um,
And to be
so
perfectly honest, like when you look at, we look at the risk of breast cancer in women that are overweight, it's higher than hormone replacement treatment. We look at risk of breast cancer of women that drink alcohol. It's higher than
Yeah.
the risk of breast cancer and hormone replacement treatment. So
So if you're
again,
drinking alcohol to cope with your menopause,
mm,
what's the difference?
yeah, exactly.
You're better
Yeah,
off with
exactly.
HRT.
And I think that's what, the medical profession probably needs to look at a little more, like, what are women doing
Mm.
to cope, and would looking at hormone replacement offset a lot of that, and as you said, just improve their quality of life, so they're not having to look at other things to cope.
Yeah,
Yeah.
100%.
Mm,
Um,
yeah.
I actually haven't really had a lot of exposure into the menopause space, really. I've
Mm,
had a lot of women who are like, this was probably back in the day where I was seeing like clients in person and doing more strength-based training. And I'd see a lot of women who were like 60, 65 up doing like
mhm.
weights and training for like, but they weren't really in menopause anymore. Like it was like, oh, I've been
Yeah.
through that like 10 years ago.
Yeah.
And then from there, like I've done most of the work I've done has been before that time.
Mm,
So I haven't, and if I am seeing clients, it's mostly for pelvic floor and prolapse rather than
yeah.
everything else in that space. But
Mm,
which I mean, I actually was having this conversation the other day with someone about prioritizing like how do you go about bone health and dealing with prolapse at the same time with like
yeah, that's tricky, isn't it?
plyometric exercise.
Tricky,
We had a big
tricky,
discussion about that,
tricky.
which is like a whole topic.
Yeah. How do you
Um,
do it? Just out of curiosity. Like what approach? Do you take an
well,
approach, or?
I think personally, I think the bone fracture side of health is way more
Mm,
risky than sort of like your prolapse is like you could get a
yeah.
pessary and like we can
Yeah.
train that up.
Yeah, yeah, yeah,
So
yeah, yeah.
I would probably go through a bit of both with like teaching really great strategies during
Mm,
exercise and doing things that are, closer legged, breath control, like pressure
yeah,
management
yeah. Yeah, yeah,
stuff
yeah, yeah.
really
Yeah,
well.
yeah,
And
yeah.
then keep the bone low. Like it also depends on,
Mm,
are they like osteoporosis? Are they in
mm,
osteopenia? Has
mm.
someone just said you really need to start prioritizing bone health? You're going that way. Kind
Yeah.
of where are they in that journey first?
Mm,
Quickly do all the core retraining that we can do as quickly as possible, and
mm,
then sort of go through there. But if they're like, severe osteoporosis, I'm like, mate, get them into
mm.
bone loading.
Yeah,
We'll
yeah,
teach
yeah.
pelvic floor stuff. Most of
Yeah.
them are like, oh, whatever, prolapse. It's been there for
Yeah,
years.
yeah.
It's not as, I don't think it's as risky
Mm,
for me, but obviously individuals
yeah.
choice. So I would probably prioritize the bone health a little bit more over the prolapse initially.
And I feel like, and there's a Michelle Wright, her name is. She is a fitness professional, quite high profile educator. I think she works for one of the, oh my gosh, my brain.
I actually went to her women's health conference back in
You know
uni.
her?
Yeah.
Yeah, yeah, yeah.
She does more like
She's
PTs, like
I think she's great.
fitness.
Yeah.
Yeah, she's
Yeah.
awesome.
Yeah. So she actually has quite, it's a maybe 4 or 5 hour course geared towards kind of PTs and
Mm.
fitness professionals. And I actually did that course. I just, I had some CPDs I needed to get done a couple of years ago, and I thought, oh yeah, that looks interesting. Um, Really great course, like really, you know, very easy to learn, really
Mm.
kind of explains things really well and simply. But that's what she said in one of the modules I did. She's like, women are never going to die from pelvic floor or prolapse issues,
Yeah,
but they
100%.
will die from bad bone health. They will die from cardiovascular disease. They could die from diabetes. They probably will die from dementia and poor brain health.
Mm.
So they need to exercise.
Yeah,
Like,
that's what I think.
yeah,
Like you said, the
yeah,
fracture risk, right? Like 30%,
yeah,
like pretty high
yeah,
for death rate.
yeah. It's like
Um,
what's gonna impact on your health the
mm.
most. Yeah,
Yeah, and I'm like, oh,
and
your
working
prolapse we
around it
can
as
fix
well.
eventually. Like, and if worst case scenario,
Yeah,
you can get surgery. Like,
yeah.
your
And
bone health, that's
you can even start like some lower impact. So it's not just the plyometric exercises, like it's the progressive resistance training that's
yeah.
also really good for bone health as well, like getting that
Mm.
pull on the bone, that loading. Um, and you can also start like some scaled back kind of impact exercises like stomping and,
Yeah.
stair climbing and, those sorts of things as well while you're, working on the pelvic floor and kind of just progress that up as, they're getting more strength, I suppose,
Yeah.
within
Well,
the pelvic floor area.
I kind of put them through the same progression to return back to like skipping for pelvic floor problems. Cause I'm like, it's kind of like the same progressions, like,
Yeah,
like
it
heel
would be.
loading, stomping, like
Mm,
small, like not as impactful, like
mm.
soft landings.
Yeah, like
And
almost your
then,
return to running kind of
yeah, it's kind of
prescription.
like
Yeah.
similar.
Yeah,
You need to
it is.
get to that
Yeah.
first bit before that, like the
Yeah.
stuff, but
And
yes.
even with some of your plyometric stuff, it doesn't have to be like loaded up and down. Like you can do sideways, you can do like, narrow legged kind of up and down. So you're kind of offsetting gravity anyway. Like,
Yep.
you wouldn't be doing jump squats or, where,
Yeah.
you've got that full loading from gravity. Like you can
Have
be
you,
doing some sideways motion or, offset that, you know, you know what I mean.
yes, I do. I'm
Yeah,
loving
yeah,
the hand gestures because I'm like visualizing it.
yeah,
Have
yeah.
you worked with reformers?
I haven't worked with reformers, but I do reformer Pilates myself. I
Yeah, like
absolutely love
the
it.
jumping board.
Mm. Yes.
Like that would be all right.
Yeah. Yeah. And I feel like as EPs, it's exciting because we have the capacity to think outside the box with those things. And you're like, well,
Mm.
this is a problem. That's also, something that coexists. And I've got to try and solve both problems at once. And how can I do that? And we are so skilled at being able to do that,
Yeah.
being able to like think outside the box, like,
Mm.
so yeah, totally agree that that would probably be something that you could implement.
Yeah.
Yeah.
I feel like the
Yeah.
biggest concern sometimes is where if you aren't really sure about one of the like
Mm,
I think she was learning more about pelvic floor and we were talking she had a menopause like prolapse client wanting to do this
mm.
bone loading and just like she has a prolapse like what should I be
What do
doing
I
that
do?
stuff
Yeah.
like or do I do this?
Yeah.
Yeah, that's when we talked about it. And it's more about the fear of
Mm,
like, what if I did it the wrong way round? Like, people's health is
yeah.
at risk. Um,
Yeah.
so I just thought that was super interesting, like when we've
You
layered
got
all
to
these
kind of,
things
I feel like
together.
you got to kind of do it at, I don't know, maybe at the same time, but just in the right way, like
Yeah.
monitor
And I've
both
seen,
and progress one up as that's improving. And yeah.
yeah. But even as you're doing that and you're improving, like you said, lateral work, you're using like glute
Mm,
work, which is going to be super supportive for pelvic
yeah.
floor prolapse eventually
Yeah.
anyway. And eventually, once they've started understanding the recruitment and their breath control properly, and they've got some
Hmm.
baseline core strength that they've done
Mm,
separate to that, they'll be fine.
yeah. Yes. And you can
So,
still do your heavy resistance training, like, and just
oh yeah,
get them working like as you would, like trying to work out what exercises, they feel the pressure and change their position or change like the machine or whatever you're working
yeah,
them on, just to get them in a position where they're not feeling that pressure. And
mm,
then just load them up. So you're still going to get that pull on the bone for that
yeah,
loading. Yeah. Yeah,
exactly right.
definitely.
So when we look
Yeah.
at like exercise prescription for like, because I'm thinking, oh, what's the prescription for menopause?
What's
But
the general one? What do we do? Yeah,
yeah,
exactly.
like, do
How do
we
you put
just
it all
go
together?
down? Yeah, what do we do?
Generally, there is a prescription. Um,
300
so
minutes.
when we look at kind of everything all together and what is needed, so there's actually some really good um, systematic reviews and meta-analysis on a lot of symptoms of menopause. So they've done a lot of work on bone, obviously, metabolic syndrome and exercise, sleep and exercise, lipid profile.
Mm,
Um, they've done a lot of studies on exercise and vasomotor symptoms. Um, they've done a lot of studies on progressive resistance training and what kind of prescription you would need for that as well and what it improves. Um, so generally speaking, you want to try and look at a combination of your progressive resistance training. Most of it is going to be like at a higher intensity to really get that loading on the bone. But there's been a little bit of research in terms of loading on the hip that a more kind of moderate intensity is
mm,
is better. Yeah.
yeah,
So
okay.
a little bit of moderate intensity, quite a lot of higher intensity, uh, pretty standard frequency prescription of 2 to 3 times a week.
Yep.
And that obviously a lot of that's going to load the bone, plus musculoskeletal system. We haven't really talked about that. So estrogen really affects that. Okay, so the way, so it's anabolic. When we're losing estrogen or it's going a bit haywire, our body becomes a bit more catabolic, so breaking down. So at the muscle, you've got a lot less activity at the myofibrils. You've got it's harder to kind of get that protein synthesis right there as well.
Mm-hmm.
So you have decrease in muscle power, decrease in muscle strength, decrease in muscle mass. Now, they're actually linked power to being the thing that is linked most to reduce function. Mm-hmm. So you want a good power prescription as well in your resistance training. Yeah. So the higher you can work, the more that exercise is going to take over where estrogen is now failing.
Yeah. Okay.
So what you might have been able to achieve premenopausal, because estrogen's there pumping everything up, you might have been able to keep a certain weight, keep yourself toned, keep a certain muscle mass, keep a certain body fat, and it might not have involved a huge amount of effort. When you're kind of going through menopause, you've got to actually go a little bit harder, because you need to push your body into that zone where it goes, holy hell, I need to work a little bit harder.
Yeah, okay.
Because I don't have menopause helping. Now, on the flip side of that, you've also got women that often aren't sleeping well. They are often exhausted. So how do you balance that out? So you need to be mindful of increased rest and recovery times, probably shorter sessions, but working a little bit harder.
Yeah. Okay.
Yeah.
So what's your usual prescription? Like,
yeah,
sets and reps wise, or is it like a RPE thing for you?
Totally would depend on where the person's at. Obviously, if you've never strength trained before, you're going to start them with, I would start
Learn
3 sets of 10 at, maybe 60 to 70% of max, and just learn the movement and make sure that they're safe. And then you want to kind of work up to that higher intensity. And wherever you can get them, really. So trying to get to a prescription where you're doing some power work and some strength work, but what they can manage, because the more the higher you can get them, the better response they're going to get from the muscle, because the muscle doesn't really have estrogen anymore that's helping like it did before. So you've just got to go a little bit harder. But but you're not going to do that every session. You might pick a couple of really big compound exercises that you're going to go, right, today you're going to really work hard on these, and then we're going to do another 3 kind of maybe more isolated exercises, or exercises that aren't as intense. We're going to kind of do those moderate. And then your next session, you might pick another couple of exercises that you put really hard on, and then the others you might just scale back a little bit. So because what we don't want to do is push a woman into massive fatigue when they're already fatigued, because then the cortisol is just going to go through the roof. They're just going to end up like in. And oftentimes, you've got women also that are restricting their diet because they're like, oh my God, I'm putting on weight, I need to eat less. So you run the risk of putting them into low energy availability as well if you're pushing too hard. So it's all starting where they're at and just working them up to the ideal prescription, but obviously you can't start there. And then we've also got cardiovascular prescriptions. So the research on moderate intensity cardiovascular suggests that possibly if that's all they're going to do, they might need to do more than 150 minutes per week, more up towards that 300 to get kind of results. And that's just because you've got to do more, because you don't have, that estrogen or that hormone profile doing what it was doing before. But a really good way that you can get around the extra volume and get really good results is to look more at high intensity interval training or even sprint interval training. If you can get your client up to being able to sustain like maximal effort, but obviously that's for a very short period of time. One of the studies that they did on sprint interval training, they did, where is it? 3 times 20 minutes a week for 8 weeks, a total of 8 hours exercise over that whole time. And women significantly increased lean mass, fitness, resting and exercise stroke volume, and resting heart rate.
That was 8 hours over the whole study.
8 hours over 8 weeks, just doing 20 minutes of sprint interval training 3 times a week.
And what did they say what the intervals were? Like how long are they at max?
I could have a look. So sprint interval training is really short, so you might even just be looking at less than 20 seconds.
Yeah, I was thinking like 10 seconds.
And then like a good 40 to 60 minutes rest or something. Yeah.
That's hardcore for 20 minutes.
Yeah, it is. Yeah. Yeah. But you get that real kind of peak effort response. The body the mitochondria just goes, holy hell, what is going on? I've been dormant forever because estrogens also affects the cell and the mitochondria and what it does and its function. And then all of a sudden you're doing that kind of maximal effort and the mitochondria just wakes up and goes, oh, I can do this. I don't particularly need estrogen. So yeah, the whole idea of the exercise prescription is to do what estrogen is not doing to get that response. Yeah. But as I said, like it's short periods. You definitely wouldn't be doing that high intensity work for more than 15 to 20 minutes at a time.
No, I'm just like, this is like,
and maybe maybe 3 times a week. Yeah. But you work up to it, you work up to it.
Yeah. Don't do it on session 1.
No. And I just literally go, where are you at? I mean, a lady I kind of was working with a couple of weeks ago, she has not exercised forever. And she's stressed, anxious, overweight. I'm like, okay, we need to just get you chill first before we do anything else. So she started yoga. Yeah. And she's walking for 20 minutes every day.
Yeah. Okay.
And when she's chill and when she's chill and sleeping a little bit better, then we're going to go a little bit harder. But if you get a client that's and that's one of the big things to check is how is their sleep? Because if they're not sleeping well and you start to push them too hard, and too hard can be, let's go and do a 40-minute walk if they haven't walked forever. Yeah. That can be too hard. That's just going to increase that stress on their body, increase that, that level of sympathetic drive, and it's just going to, make things worse. So it's definitely a lot of, good assessment as well, finding out exactly where your client's at with their menopause journey and what's affecting them, and just building that exercise program around it. And it might take you 12 months to get your client to that, ideal prescription where their body is really responding and they're losing weight and they're building muscle and they're building bone. It might take 12 months. Yeah. But again, it depends on where they're at.
It's pretty hardcore exercise, really, when you think about that prescription. It's almost like full-blown sprint training and powerlifting together. Like, it's like
but you're not going to do that. Definitely not going to do that on the same day.
Oh yeah, no. If they can do that, they're definitely like, they're like elite level athletes. Even then they don't.
It's like 2 to 3 sessions a week.
Yeah.
So you might, and in between that, you're going to do rest, recovery, good diet. So their rest and recovery might be yoga, Pilates, walk with the dog.
Yep.
So you can see how it's increasing intensity, but very much a reduced volume.
Yeah.
So you're not pushing that sympathetic drive too hard.
Yeah. Okay.
Yeah.
Interesting.
Wow. I hope that makes sense.
Cool.
Yeah.
It is. Like I said, I don't go outside of pelvic floor anymore. Like I haven't really gone into like proper programming prescriptions outside of strength training. So I don't do a lot of reading up on like, how do I increase this? Because I'm usually like, this is now, this isn't my thing. So
And in
it's really
saying all
cool.
that though, I guess if you get a client who's not overweight, who doesn't have osteoporosis, who is not having like really bad kind of vasomotor symptoms, has good cardiac profile, doesn't have anything going on with insulin resistance, and doesn't really have a lot of those physical things, but maybe is depressed and not sleeping, you're probably not going to do that, that real kind of high intensity stuff. You might just go, all right, well, let's just go with a nice moderate intensity program that's just getting you moving, like that's just getting you out of the house, that's getting you into the gym around other people. If they don't have a lot of physical
Yeah,
markers,
I
you
don't
may
need it.
just go with a very low key one.
Yeah.
Some yoga, some Pilates, some mindfulness stuff, breath work. Yeah. So again, it's, being EPs, we do a good assessment and we prescribe based on the client's symptoms and what's affecting them the most and what they need.
And so the type
Yeah.
of prescription that you were talking about before, I'm thinking like, so for me, when I've heard like vasomotor, I always say that one wrong.
I know.
Um, like I would have just assumed, oh, well, that's like, I can't really do much about that with exercise. But from what I've learned, what we're
Yeah.
doing exercise prescription wise can actually improve those symptoms as well.
Yeah, definitely,
Yeah.
definitely. Yeah.
Wow. That's awesome.
Well, originally they thought it's a secondary effect of someone losing weight,
Yeah.
someone
Okay.
reducing their inflammation, but they're kind of the research. I think even 5 years ago, perhaps, and kind of 5 years ago and onwards, shows that it's definitely also to do with the responsiveness of the vascular system at the periphery as well. So that's helping lower cardiac risk, but it also helps the thermoregulatory system in the brain know what's going on better because your vascular system's much more responsive.
Yeah. Okay.
You're keeping those veins and arteries like nice and flexible. The
They're
blood pressure's
responding to
low.
exercise.
So
Yeah,
yeah,
as
the
well.
endothelial function is good. And so that's going to help with vasomotor symptoms because that part of the body is responding really well and sending good signals back up to the brain. So the brain might still be going, not quite sure what's going on, but you're going to get an improvement
Yep.
because you're getting better signals up into the brain. So there's that,
Yeah.
but there's also a lot of research that exercise can help with how the hypothalamus is interpreting those signals as well. So yeah,
That's so cool.
yeah, it's really good. Yeah.
That is cool. I've honestly ever thought menopause exercise prescription was like bone health, weight loss, and cardiovascular health. Like
Yeah.
just prescribed for that.
Yeah. And a lot of the vasomotor symptoms as well are in like the way the brain like how it all happens um is a function of serotonin. So
Yeah.
estrogen is very interrelated to serotonin, crosses the blood-brain barrier, affects serotonin, in conjunction with like, oh God, what protein is it? There's a particular protein. Is it tryptophan?
Tryptophan, I think, is
I think it's
from memory.
tryptophan.
Yeah.
Yeah, I think that's so the same interaction for mood as well. So helps with mood, but also helps regulate kind of serotonin a bit better, and that's also all related to vasomotor symptoms as well. Yeah,
Yeah,
so exercise we know affects and improves all that, so that's going to have a crossover effect into improving not only mood but also vasomotor symptoms and brain function, and yeah, it's all interrelated.
exercise just blows my mind every time I learn something new about it.
Yeah, I know.
Yeah,
Yeah, it's
so cool.
amazing.
It really is.
Yeah.
Um, I don't really have any other questions about menopause. I feel like you've covered so much. I've learned quite a lot in this, which is awesome. So thank you for sharing.
I could talk about it more, but it's probably
We can do it as an
how long have
episode
we
2.
been on here for? Yeah, we've been on here for a long time.
We've been on here for a while. Yeah, that's okay.
We've just had a good old chat.
If someone like if there's for everybody listening, if they're looking to like connect with you or they want to
Mm.
send someone to your page or maybe they want to like
Yep.
join in or like
Yeah,
send a
yeah,
blog
yeah.
post if you're
Yeah,
interested
yeah.
in blog posts,
Yeah, yeah, yeah.
can you share where you're from? Like where they can find you? Sorry.
Yes, yes. So She Community, SHE Community. So you can just search that on Facebook. I've got a Facebook page. Instagram, I always bloody forget it. Where's my phone?
I will share it in the show notes with a link. So if it's easier for me to do that. I feel like there's an underscore. Is there an
Let's
underscore?
have a look. Yeah, it's she dot community dot x physiology.
Ah, yes, that's right. You better
That's
practice that one
Instagram.
a bit more when people ask.
Yeah, I know. I need to. You
Something
know how
with
you go through a
community.
million like ones and it
Oh,
goes, nah, that one's taken, that one's taken. I was like, oh God, I'll just put a
yep,
few more dots in it and shorten a
yep.
word. Yeah.
Underscore, underscore, underscore.
So that's the Instagram. And then we've got shecommunity.net is the website.
Yep.
And hello at shecommunity.net is email. So I would love to hear from any females that would love exercise physiology help. So I operate mainly online. However, I am in the Blue Mountains, New South Wales. So if there's anyone local that would like to be seen face to face, can definitely do that. I'd love to hear from other allied health professionals that would like to get involved. I would really love for anyone to do a blog if they want to, provide any more information. If anyone's like in a regional area and you don't have anyone that can help your local population with menopause related clinical exercise prescription or, just general information in general, yeah, direct them my way as well, because I'd love to help out regional females that don't have any local services as well. Yeah, so
So good.
that's where you can find me.
Cool. I'll put all your information below anyway so people can refer back to
Yeah,
it. So,
yeah,
but
yeah.
otherwise,
Great.
thank you so much for sharing and being on the show.
Been amazing. Yeah, thank
Lovely.
you. Thanks for having me. It's
No,
been really
you're so
good.
welcome. We might have to
As you
do a
can tell, I
second
could
one.
talk about it forever.
Yeah, I feel the same about pelvic floor, don't worry.
Yeah, I know. It's like one of those things that like don't get me started because I might not stop.
Yeah. I know the vibe. I feel the
Yeah,
same.
yeah.
Like
And if
just
there's any allied health professionals out there that just have, menopausal clients and they're just stuck and they don't know what to do, like just reach out, and I'm always happy to have a phone call. And yeah,
yeah,
that's
that's
what it's all
awesome.
about, just getting the word out there. And if I can help women just make that time of their life a little bit easier, then it would be fantastic.
You're like, it's
Yeah,
hard.
it is, but I think it can be made a lot easier if we just, it's all about empowerment, like education and knowledge. And if you know what options are out there to kind of help you get through it. Some women can't take hormone replacement, some women don't want to. But exercise can, yeah, is such a powerful tool to have in the toolbox. And if women know that, then yeah, I'm
100%.
all for it. Yeah.
Very good. Well, thank you again. And
Thank
hopefully we'll
you.
chat again another time. But otherwise, thanks very
Yeah.
much.
Yeah. Thanks a lot, Courtney, for having me. It's been great.